From the JAMA Network, this is JAMA Psychiatry Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Psychiatry.
Hello, and welcome to our listeners around the world. You're listening to the JAMA Psychiatry Author Interview Podcast. I'm your host and web editor, Dr. John Torous. Today, we're thrilled to be discussing a new paper just out in JAMA Psychiatry, Incidence and Nature of Antidepressant Discontinuation Symptoms, a Systematic Review and Meta-Analysis. We're about to be joined by the corresponding author of the paper, Dr. Jauhar, MD, PhD, Division of Psychiatry at Imperial College in London, UK. Antidepressants are some of the most commonly prescribed medicines and help millions of people around the world. While, of course, side effects do exist, often they're minimal or can be addressed by switching to a different antidepressant medication. But there's a different challenge around these medicines that sometimes we consider less and know less about. What is the incidence and nature of symptoms following discontinuation of antidepressants? Is there a discontinuation syndrome? To learn more, we'll explore the results of a brand new study just out in JAMA Psychiatry. Thank you so much for joining us, Dr. Jauhar. And to jump right in, what is antidepressant withdrawal syndrome?
The easiest way of describing, and we've known about it really since the 1950s, since the inception of the medicine, and these are symptoms that are attributed to the pharmacological effects of stopping the medication. And they've been described over time, though the classification's never been very clear. And I guess our way of understanding it currently would be physiological effects and psychological effects.
As you and the team write in the paper, there's a lot more that we don't know about what this discontinuation syndrome.
Yes.
What was the state of the current literature or clinical knowledge before you and the team did this work? Give us a crash course since 1950s to 2025.
It's the nature of evidence-based medicine, isn't it? And it's the evolution of how we describe things. So you had case reports, and then you would have some systematic reviews. You'd have some trials, but the trials were efficacy trials. So these were trials that were never really made to say or address the question of discontinuation symptoms per se. So essentially it was indirect evidence that was being applied and conjecture. And whilst we can understand complexity, I guess people wanted a number.
Yes.
Which is wholly understandable. You know, people wanted to be able to quantify how often are these symptoms occurring in people and what's the nature of them. And about 8 years ago, there was a review that questioned this because with the dawn of the internet age, you had people legitimately saying we have these symptoms, but being unable to quantify which proportion of people, when they come off antidepressants, will develop the symptoms. And there were various reviews done with various methodological strengths and weaknesses. But really, the field didn't come to an agreement in regard to the incidence, heterogeneity, and putting things together to serve, as you might say in the States, Joe Public.
That's a lot if you're saying we don't know the incidence, we don't even know the prevalence, we don't even know what it is, but we may have patients reporting that they're having symptoms when they stop these antidepressants. And clearly, these are symptoms people don't want. This is not a positive thing to have a discontinuation syndrome. So to answer this question and bring a little bit of understanding to the space, you and the team did a systematic review and meta-analysis. What type of papers and studies were you looking to put into it, and what would make a study eligible to fit into this review that you were doing?
The weakness that we had was the nature of the studies included. You were including surveys and observational studies. And in evidence-based medicine, in terms of our hierarchy, top of the hierarchy has to be RCTs. So we had to be very strict and say that we will only include randomized controlled trials, and we'll also look at placebo as well and be able to measure things. That's where we can get some degree of certainty. So our inclusion criteria are quite strict in regard to RCTs and then elucidating things from there. We had published and unpublished data as well. So we did contact pharmaceutical companies for data, and that's all in the manuscript and all very clear if people want to read through all of that.
And 50 studies made the final cut, and this represented 17,828 participants. This is a large number. It's a lot of studies. Let's talk about who are the participants in these 17,828? What conditions were covered? Who is the sample that we're going to talk about and learn about discontinuation syndrome from?
Essentially, it's people taking antidepressants for a whole host of different conditions, so not just specifically depression. It's people taking them for other disorders that we might give antidepressants for. So, for example, anxiety disorders and other disorders that you see generally in psychiatry, though the majority will be people with mood disorders. But across the spectrum, because you're asking a physiological question, your primary question isn't to ask, is it disorder specific? That'll be a secondary output. We're casting the net out wide, transdiagnostically, looking across studies and looking at compounds as opposed to anything else.
There's so many fascinating results in the paper, and I'll try to break them up in some ways, but let's dive into details of 18 studies assessed discontinuation symptoms using a continuous scale, and were included in a section in the paper you call these are the continuous results in the meta-analysis. Let's talk about what you learned from the continuous, and let's actually start, what do you mean by continuous results?
You'll have a scale such as the discontinuation side effect scale, DESS, which is patient or clinician rated, on a continuous scale of severity across a number of domains. And that's going to be better than dichotomizing whether someone has a symptom or not. And I think one of the weaknesses before is that people might say, you might have 4 symptoms, but we have no way of measuring the severity of those symptoms. I could have 4 very mild symptoms, and someone might score that as very severe, as they have done in prior meta-analyses. If you want to know the rate of severity that people are giving something.
So we have these 18 papers that again had this really nice continuous scale that was perhaps a nice way for you and the team to assess what's happening with the severity. Let's just dive into, what did you and the team learn from those 18 studies?
I think what we learned was that symptoms definitely exist for people, but according to the categories, some come out much more clearly than others, and they come out much more clearly as a pharmacological effect as opposed to non-specific effects compared to placebo. And that's what struck me as a clinician.
Let's break that down to, what are the categories then that you saw that are most striking?
I think the striking ones would be the neurological symptoms, the psychiatric symptoms, and gastrointestinal ones. So, for example, the neurophysiological electric shocks, dizziness, gastrointestinal nausea, and the psychiatric ones are much less specific. So, for example, a little bit of anxiety or irritability or insomnia, as opposed to really having the validity that you might see with those other symptoms, which are just much more clear. If someone has ZAPs, it's a very much more clear, defined phenomena than anxiety or mild irritability.
No clinician wants patients to have dizziness, electrical shocks, or irritability. How common or severe overall were these symptoms coming up in people stopping antidepressants you found from these continuous scale studies?
No, absolutely. And that's in our supplementary. But I think the big message is less than 10% for the non-specific symptoms, and more so for the ZAPs, for the dizziness, and those sort of specific ones that you could attribute it to pharmacology. And that's quite nice and neat for me, as opposed to anything else.
When you say pharmacology, we just expect when there's less of the drug in the brain, there's going to be an adaptation period, or it's going to be time limited. Is that what we mean?
Precisely. And electrical zaps, people don't tend to get them in psychiatric disorders per se, whereas this is a much more distinct phenomena as opposed to things like anxiety or irritability. And what was striking was the low rate of these sort of symptoms in the placebo groups, which I think was the big thing for me.
And individual symptoms were assessed in 45 of the 50 studies, which is a lot. What were we learning about individual symptoms? We've already dove into it, but maybe more numbers or prevalence, or things that we can sink our teeth into.
No, absolutely. So things like individual symptoms, again, as I was saying before, about 30% of people that you're starting to see things like the ZAPs and the electrical impulses as opposed to anything else. Less than 10% the non-specific ones. And that's all within the first 1 to 4 weeks of people stopping the antidepressants. And there's quite an appreciable change there. What I would stress is the fact that you're not seeing in the placebo group some of these other symptoms. And that suggests clear phenomena as opposed to anything else.
In light of depression, someone who stops their antidepressant may potentially develop depression. Again, we know it's a common disease that comes back, especially for people who need to be on antidepressants. How do we separate a discontinuation syndrome from this is depression returning and we actually need to be back on the medicine itself?
I think that's a weakness of some of the previous literature. So people might report non-specific depression symptoms, and that might have been put down as a depression relapse when it isn't the case. What's interesting about what we said before, things like dizziness, brain zaps, if those are present in such a higher degree, that's going to discriminate whether something's withdrawal phenomena then associated with relapse. So for example, if you had clear core depression symptoms in the absence of these other symptoms, odds are that's more likely to be a relapse than anything else.
Do we have a sense of how long those uncomfortable neurological symptoms may last for based on the results?
Usually within 1 to 4 weeks. But you have to bear in mind that the follow-up period for the included studies is usually only up to about 6 weeks. We do have data from RCTs such as the Antler RCT in the New England Journal, where it's a bit longer, but you just don't have the accumulation of data in that regard.
Are there other results that you want to make sure listeners are aware of?
No, I think those are the main ones, because as soon as we start making things complicated, we could go through every single symptom that every human being gets. And I think even for me, for the chunking of my working memory, it's quite nice to know, as you've said, something's neurologically distinct. We can separate that out from non-specific symptoms. And so for me, it's things like the zaps, the dizziness, vertigo, to a lesser degree, the GI symptoms, which all make clear sense, as you said, with the serotonergic and noradrenergic systems. And if we can just anchor onto that, it makes it a lot easier, because these things are much more common. You're not seeing them in the placebo groups. And for want of a better word, it does validate the patient experience. When they do come with something, it's getting recognized and looked after.
For clinicians listening, what would you want them to take away from these results, or maybe to be able to explain to patients who are considering stopping the antidepressant? Would you want to call out any certain antidepressants or give them any advice to improve their clinical practice given you discovered all this new knowledge from the review?
To be honest, it's a lot of stuff that you'd have picked up intuitively. We've known paroxetine, venlafaxine, drugs with short half-lives, or paroxetine, which induces its own metabolism, for example. Those have always been more likely to cause the symptoms. Great heterogeneity within compounds, and obviously there's heterogeneity between compounds. And I think that's important, because we're looking after individual people with individual medicines, and to say all antidepressants cause withdrawal, I don't think is particularly helpful.
As you said, classically, the shorter half-life medicines will cause it, but as you said, people are different. Most patients I've had have not had symptoms overall, but I think it's hard to predict which patient is going to occur in, and I think that's something we still don't know, right?
We know this from our clinical practice, and it's good to just put something out there that's clinically meaningful and clinically focused. And people will do their own studies and targeted studies. They'll focus on those things. And then you're going to have a lot less noise. Because what struck me, and I probably should have brought this up before, is the amount of noise in the data before, because every symptom is in there. And hopefully what we've been able to do is just extricate and be much more specific. And then patients, when they present with things, I think it's just neater for them.
For patients and family members listening, we're saying clearly antidepressants are effective. There may be withdrawal symptoms, but they don't seem to lead to psychiatric symptoms or worsening of psychiatric conditions, or maybe these transitory neurological symptoms that are uncomfortable but would go away, and they're not overall that common, considering how common these medicines are prescribed and used. Anything else you would want patients and family members to know or be aware of as they go forward?
I think it's a reassurance. There's the caveat, obviously, that these are short-term studies and that biological systems do change over time. But from what we do have, that's what we can glean. And if you do present with things, your doctor will be able to go through things, and to have some faith in the system and some faith in evidence-based medicine. And if someone does have major symptoms out with the neurological symptoms, odds are that's relapse. Just like if you think about it, I guess, when someone stops ECT.
We have to be careful and alert, but it's good that now we have some clearer evidence on what these symptoms could be, what they may mean most likely, and what they may not mean. That's all the time we have. I'm John Torous, and I've been speaking with Dr. Jauhar about the incidence and nature of antidepressant discontinuation symptoms, systematic review, and meta-analysis. To learn more about this research, you can find a link to the article in the episode description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Shelley Steffens at JAMA Network. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.